Let's talk a little bit about the recent article and the umbrella review that was done regarding serotonin and depression.
One of, one of my favorite topics at the moment. Yes.
And the articles and the reviews seems to suggest that physicians have been suggesting that serotonin is the root of the deficiency or lack of serotonin, the root of depression.
Right.
I used to have this huge book, the Physician's Desk reference book.
Mm-hmm.
And I remember looking through it so I like pharmacology. Because I learned so much about physiology by reading the mode of action of medications.
Right.
And so that's why I'm always asking, what's the mode of action? How does that work? I'm into the physiology of things.
Good.
But a lot of the times when I looked at these medications, most of the time, you always had the language that said, it is thought that, it is believed that, evidence seems to suggest that. I don't really recall a straight answer saying depression is caused by serotonin deficiency. Have you come across any literature that actually adamantly says that serotonin deficiency?
I haven't. And actually, I took a continuing education course several years ago that was the instructor was a pharmacist who's also a licensed professional counselor, which I thought was funny. He can fill your prescription and he can recommend that you go talk to your doctor to get a prescription, but he couldn't write the prescription. But he was uniquely qualified for this course he was teaching because he understood depression and anxiety and all the mental health disorders and was a therapist and how to treat them. But he was also a pharmacist, so he fully understood exactly what you said, the mechanism of action for medications and how they work on the body and how they interact with, different things that you're doing or taking and all that. So it was a very, very interesting course. But he said repeatedly, especially talking about antidepressants, we are 100% in the realm of theory here. We don't know. And he mentioned I think there's 7 different types of serotonin receptors they had identified then. This was more than 15 years ago, so I'm assuming there's probably more.
I think last time I read were 15 that they've identified.
Yeah, so at the time they're talking about like 7.
Right.
But they only knew what about 5 of them did. And 3 of them were related to digestion. So, he's like, we really don't know. We think this is what happens. We think that they are increasing serotonin levels. And he said one of the kind of issues with especially SSRIs and medications like that is, we can, and this is the way SSRIs are believed to work, is increase the amount of serotonin in those synapses, but we can't tell the body where to put this increase of serotonin. So it's not like we can say, okay, you're going to take the serotonin and bond it only to the mood receptors. So that's why a lot, and he kind of mentioned this, and right before he mentioned it, I was like, oh, I wonder if, and then he confirmed it. That's why a lot of SSRIs have a lot of digestive side effects because serotonin is involved with digestion. And it's why depression and anxiety have a lot of digestive and gastrointestinal symptoms because serotonin is so involved in that.
In fact, the gut has a lot more serotonin than anywhere else in the body. I mean, much more than
exactly. The brain. One estimate I saw said about 85% of the serotonin in your body is actually in your gut.
Right.
So, it's even that. So as you mentioned, if you take a pain med, they can tell you how it works. If you take an antibiotic, they can tell you what it's doing. And that's one thing he described is why we're in the realm of theory when you're talking about mental health disorders is, if they're trying to develop an antibiotic, they can put a whole bunch of bacteria in a petri dish, put that chemical in the petri dish and see how much of it how much of the bacteria is killed by it. They can't put depression in a petri dish put an SSRI in there and see what happens. So,
Right.
So as I said, it was a very interesting study, but all the research I've read, and anytime you talk to like a pharmacist or somebody who's really into pharmacology, they'll admit we think this is what's happening.
Right.
I had actually, and I had seen some research before this umbrella review that questioned that. Is this really what's happening? Are we really going down the right path? Are we really telling patients the right information? And then this umbrella review, which looked at, of course, existing literature going back, I believe, a decade, including a genetic study that had, well over 100,000 participants. And their conclusion was that there doesn't appear to be an association between serotonin levels and depression.
Or perhaps that there is no association of serotonin being the only reason for depression.
Right.
Because when I looked at some of the studies or the research on the Alpha-Stim website, and it was indicating that cerebrospinal fluid show higher levels of serotonin after
following a CES treatment. Yes.
Right. So unless, serotonin doesn't last that long, and I think maybe perhaps looking for the metabolites of serotonin might have given a better indication. But the fact is that according to what I read there, they were higher, including other neurotransmitters, beta endorphins, and so on.
Right.
So we can't really say that serotonin does not play a role. It's just not the only role.
Right, exactly. And I don't think the human body is so easily categorized as to say one thing causes anything. Right. So even, conditions, like, heart disease, there for a long time, it was, diet is the cause of heart disease. Well, okay, great. But what about that marathoner that eats healthy and had a heart attack? So there's a lot of factors that play into anything involving the human body. And so I always thought it was an oversimplification to just say, oh, well, it's just serotonin, or it's serotonin and norepinephrine. Trying to say it's only a chemical disorder, I think, takes some of the opportunity for helping people out of it. Because if it's only a chemical disorder, then your only treatment option is medication. And medications work sometimes they don't. Sometimes it takes a long time to find the right combination. I think looking at the electrical activity of the brain with these disorders, and the electrical activity is influenced by a lot of environmental factors, personal factors, genetic factors, as well as we're able to influence the electrical activity in our brains. So, if I tell you, if you've got if we're looking at, say, fMRI differences, and I tell you a sad story, really, really sad story, the electrical activity in your brain is going to change based on that. Maybe not a lot, but it'll change. And as I mentioned earlier, the electrical properties of the brain control the chemical properties. So, and vice versa. It's not strictly a one-way relationship.
Exactly.
It's symbiotic. Everything in the body is symbiotic. So, but with CES, our primary mode of action is that electrical activity in the nervous system. And then by balancing that and affecting that, downstream, it'll have an effect on neurotransmitters. But the primary focus, the primary mode of action is that electrical activity. Right.
So eventually then downstream, there will be some chemical involvement in it.
Yes.
Right. You mentioned earlier about the veteran that you stopped the treatment after about 20 minutes. What determines the dosage? How long should you keep the unit on a patient?
And that's like I mentioned earlier. So The correct dose for Alpha-Stim is an inverse relationship between the current that they can tolerate and the amount of time they need to treat. So if there's someone like me that can't tolerate, very, very high levels of current, and high being relative here, because at its highest, Alpha-Stim is about half a milliamp in electricity. So it's still minute. For most people, it is a completely subsensory treatment. Most people, if you feel anything on your ear clips or at where the electrodes are, what you're feeling is the spike in our waveform that's designed to disrupt the electrical activity, or the skin resistance, electrical resistance in your skin. And so that lets our waveform kind of get into the nervous system very easily.
Glad you said that.
Yeah, so that's what you're feeling. You're not feeling the current. You're not feeling the waveform. You're feeling those spikes.
Do you desire to feel the spike?
A lot of people don't feel it, and that's perfectly okay.
I see.
I don't really feel the spikes when I put the ear clips on. What I feel is the dizziness, but I also get motion sickness very, very easily. Mm-hmm. So I think that's what it is. I think anything that starts to mess with influence my inner ear gives me vertigo. So, and I don't know for a fact that's what it is. I'm kind of doing an informal survey when someone calls in and says, hey, I put this on at a level 1 and I got dizzy. One of my questions is, do you get motion sickness easily? And a lot of people say yes, but some say no. So even that's not 100% what the reason is. Right. Just everybody's nervous system is different.
Right.
And so if they can go to 250 to 400 microamps without feeling that dizziness or that discomfort, then they only need 20 minutes of treatment. If they're between 100 and 200 microamps, then they'll need a full 60 minutes of treatment. So.
Got it. So when you have the probes in the ear, is there a region of the ear where it's more effective? Maybe there's less collagen, less fat, or more of it?
So you can move it around different parts of the ear to see where it works best. Mm-hmm. Our recommended placement is on your earlobe as close to your jawline as possible, because there is a nerve cluster there. And so you put it there and it's going to travel, it's going to hit more of that nerve cluster and go into your inner ear.
You mentioned the 8th cranial nerve innervated in the earlobe.
Mm-hmm.
I have read where at times they were put in, I'm assuming by way of pads, on the eyelids.
So that was the 1950s or 60s when they were trying to kind of figure out best placement. And so they would do that. They would somehow or another put electrodes on the eyelids and on the back of the brain to get that current going through this way instead of ear to ear. And left to right is the more preferred method now for any CES device. There's some that use sponges on the temples, or some that use, the big headphones. We use ear clips. They're generally pretty comfortable and unobtrusive. And but they used to do that. And then what they found was like vision blurring and those, the flashing lights.
Right.
Just from the optic nerve it wasn't doing any damage. It was just that optic nerve being stimulated. We still have people now, even with putting it on the ear clips, if the current, they may not feel dizzy, but they may see flashing lights from the current hitting their optic nerve. And it's not at all harmful. We just say, go ahead and turn it down until that goes away. So
far out. I have really enjoyed this. I have learned a great deal.
Well, thank you. I have too.
And I want to thank you for taking your time and coming to this. I look forward to continuing to use the unit in my practice. It has helped a lot of my patients. There's a lot to learn.
All right.
And
I'm glad to hear it. And, EPI offers free customer support, clinical support, and technical support for the life of the device. So if they have any issues with their device or trying to figure out how to use it best for them, call our toll-free number Monday through Friday, 8 to 5. Central Time, and we'll be more than happy to help you out.
Thank you very much. I appreciate you coming here.
All right. Thank you.
We'll talk soon. Thank you, sir.
Yes.
Bye-bye.
Bye.